So on for the last section of this symposium, 2024 symposium. Well, there is psychedelic research happening in Belgium, and we've invited not almost, I think all the researchers who are doing or who intend to do research in Belgium. Every one of them is going to come and present their research in just a nutshell. For a swift change of speakers, I would ask all of them to come and sit down on the stage so we can swiftly change the speakers at the rostrum. And these researchers are, as you can see, Laetitia Vanderijst, Felix Hever, Cisse Geleyn, Paolo Cardone, and Aminata Bicego. Tu commences?
Hi again. I think there is a problem with my slide, which is supposed to look very nice, but all right. Well, that's a shame because it was really the prettiest slide of the whole thing. But what? Felix, and who else is missing? I don't know. Who else is missing? Just Felix. Is Felix here? No. Okay. Well, I'm just gonna start. Wait, I have another nice slide. Yeah, no, they are all ruined. Okay, anyways, so I wanted to start, I'm just gonna keep this as background, with something that I want to address, and I think Tadeusz already addressed it, like, you know, there are many problems with clinical trials, really many problems, and we cannot go into depth. And there is indeed, you know, retreats, people working underground, people doing very good work, people doing less good work. There is all of that, and that's great. I mean, some of it is illegal, but probably it's therapeutically great. But what we need to understand, and what we see in the practice of this clinical trial, is that in terms of patient access, it's not that great, because there is a lot of people that live with major psychiatric disorders that are just scared, you know, of going on this retreat or of seeking underground therapy, or don't have access to the information. And that's where, you know, it's important to also go towards market regulation, even though sometimes it feels like, you know, making a pact with the devil or something like that, because there are many problems with clinical trials. But so that we can try and make access broader and to also include people who sometimes might need it the most, not only for financial reasons, there is also a whole bunch of cultural reasons and other fears and such. So my trial, as you can not read, is psilocybin-assisted therapy for severe alcohol use disorder. This is the room which you have seen before, and it's at the CHU Brugmann University Hospital here in Brussels. So just very quickly, I'm gonna take the pointer. Why do research into, you know, alcohol use disorder treatment? It's because it's quite, you know, prevalent disorder. I think we all know someone who has, you know, alcohol use disorder or suffers from their alcohol consumption. The prevalence in Europe is about 9% of the population. And we have in Europe 10% of all deaths attributable to alcohol consumption, because alcohol is also, you know, very unhealthy and is a risk factor for cancer, Alzheimer, and other diseases. So very quickly, from the first wave of evidence, this is again a meta-analysis, so you just have to look at the bottom thing. There was some research into LSD for alcohol use disorder, and actually there was quite rigorous research with a control condition, and two authors in 2012 pulled this data together from the 50-60 to do a meta-analysis, and it seems that, you know, LSD versus control is more effective in reducing alcohol misuse. And you can see here the follow-up. So some studies had the first follow-up at 1 month, others at 12 months, so it's quite heterogeneous. So this gives some, you know, evidence from back then that it might be a useful treatment. Here also it's 1 dose of LSD. Here is some more recent data, which you can see psilocybin-assisted therapy for alcohol use disorder, which with 2 psilocybin sessions that you can see here. And the group in blue is the group that received the placebo, but the same therapy. And you see that the group that receives, I'm wrong again, the group in blue received the psilocybin, and the group that received the psilocybin shows a stronger decrease in terms of heavy drinking days and drinking days. But you can see that both groups actually show quite a strong decrease in drinking. And it can be attributable to many things. The therapy that's provided, the feeling that it gives people to take part in a clinical trial is quite a big project, quite a big investment. You get a lot of intention and so on. The follow-up is until 6 months post-treatment, so it's quite interesting to see these results sustained. And you see here that in terms of abstinence and no heavy drinking, the people who receive psilocybin do significantly better or improve significantly more. Here you can see it like it's the p-value is significant. What there is to know about this study is that it seems to be not super representative of the severe alcohol use disorder population. It was conducted in the US, and it seems to be people who drink and have a problem with their alcohol consumption, but they don't drink as much as what we can see here, in the clinic. So now the study. There were several goals to this study. First, to know if it's feasible to give psilocybin-assisted therapy to people who are for 4 weeks in an inpatient setting, so hospitalized for alcohol withdrawal. Is it effective? What are the associated mechanisms? We are diving into, neural mechanism, psychotherapeutic mechanism, psychological mechanism, kind of the same. And how do participants experience it? We have a whole range of interviews because we really want to dive into the lived experience of participants. But there was a larger overarching goal, which was, to launch a trial in Belgium, basically, and to start raising awareness and to develop infrastructure and expertise and to contribute to that. And actually, in parallel with Cisse, who will present this project, because we started almost at the same time. And so, is it big enough? So you can see here we are on a 4-week inpatient setting. So to nuance a little bit what Felix said, there are 2 integration sessions, but people are hospitalized. After the psilocybin experience, they are still hospitalized for 1 week, and then there is a 6-month follow-up. So we don't, just leave them in nature, but still it's very minimal. And this is mostly for financial reasons. We have very, very strong financial and organizational constraints in clinical trials. And so people are screened. We wish to include 62 participants. It's going very slow. And the first week, they are just withdrawing from alcohol with benzodiazepines, which is, to limit the symptoms from withdrawal, which can cause death in the case of alcohol. And towards the second week, we start with the preparation session, 2 times 2 preparation session. But in the context of the inpatient, they also have group therapies or group sessions talking about their relationship with alcohol and relatives, relapse risk, how to manage that, and so on. Then there is 1 single administration of either a high dose of psilocybin, either a low dose of psilocybin, which is still psychoactive. So it's an active placebo. It's not 1 milligram, it's a bit more. And then the last week, we have the 2 integration sessions. And after 1 month, people, go home or get out of the hospital. In terms of outcomes, we look at alcohol consumption before and after. Our primary clinical outcome is 1 month after, because we know that within the first month after an inpatient detox, 50% of people relapse. So we want to see if we can reduce this percentage in terms of relapse. And then we have a longer follow-up of 6 months. And so the first month we see participants every week. We also look at other clinical outcomes such as symptoms related to trauma, depression, anxiety, because we do not exclude people with depression, anxiety. We do exclude people with active PTSD. And then we are also looking at markers of neuroplasticity, alcohol cue inhibition, and reactivity. And as I said, conducting interviews before to assess motivation, fears, representations, quite quickly after the psilocybin experience, and then 1 month after leaving the hospital. as Dimitri, who's not there anymore, discussed, there is this question, does the quality of the psychedelic experience influence the therapeutic outcome? And so we measure the quality of the psychedelic experience. We have a mystical experience questionnaire. We also measure trauma processing with a new questionnaire, which is called the Helioscope questionnaire. And we also measure acceptation and avoidance with the APEC questionnaire. So yeah, that's it, a very brief overview. It takes a big team to conduct such a trial, so I want to thank Felix, who is a doctor and therapist on the study, Janaina, my colleague, or colleague who is not there, she's a psychotherapist on the study, the whole team, of the Brugmann Hospital and other collaborators, and the interns that have worked on the study. Thank you.
So, okay, my slides are just after this. Okay, all right. So, let's say literally and metaphorically, I'm working in Laetitia's footsteps. So this would be a second study. It's a project that has not started yet. It would be psilocybin-assisted therapy for cocaine use disorder. So a second psilocybin study at Brugmann Hospital. So I have introduced myself. I have no major conflicts of interest. And as you might have heard in the media, so not only psychedelics are in, but also cocaine seems to be very in. Everybody seems to be doing lines at parties, and everybody is smoking crack cocaine in the streets. But I mean, joke aside, cocaine is a real problem because it's a highly addictive stimulant. It's estimated that about 1 in 5 people gets addicted to cocaine who use it. In the last 10 years, the number of patients has roughly doubled. So number of patients who ask for help in Belgium about their cocaine use. The disorder has a high morbidity and mortality rate, and also a very high relapse rate. As you might see here, the blue line is cocaine. 1 year after treatment, there's roughly an 80% relapse rate, which is worse than alcohol or heroin even. There is also no approved pharmacological treatment as of yet for cocaine use disorder, which is a real problem. So, could psilocybin-assisted therapy be a solution? Well, we don't know yet. That's why we have to study it. It might be a promising treatment for addiction, for alcohol use disorder, as you have heard before. And there is one randomized control trial that has been completed in the US by Peter Hendricks and his team. There is encouraging preliminary data, and hopefully the study will be published soon. So this would be our little project. Patients would also come in for cocaine withdrawal at the hospital, or more or less 3 weeks stay at the hospital. And we would start small with an open-label feasibility trial. And if everything goes more or less well, then we would start a randomized controlled trial. Why start small? Because patients with cocaine use disorder are notoriously difficult to retain in studies, and the dropout rate is quite high. So we want to test before going large. So the design is very similar to Laetitia's study, integration, preparation, and psilocybin 5 compared to 30 milligrams. Of course, the endpoints, so we want to know, does it help the patients? Do they take less cocaine after the treatment? So we would measure the percentage of days abstinent at 1 and 3 months. So maximum follow-up is 3 months. And then there's a lot of other secondary outcomes. I cannot go into them all. One more speculative idea I had is to measure sensory gating before and after the therapy with EEG. And sensory gating is something that is impaired, for example, in schizophrenia, but also cocaine use disorder. So it would be interesting to look at, does it change before and after therapy, or maybe even could impaired sensory gating be predictive of outcome, or maybe even of the quality of the experience, maybe more paranoid thoughts or more auditory distortions. So, as you have seen, it's quite similar to Laetitia's study, and maybe I can sense some of you. I know some of you who might ask, why not do more? Because I have heard a lot of people commenting, and I heard all of these and more. So why not do fMRI, for example? That would be great. Why don't do a longer follow-up? Why don't you do more therapy or better therapy? I know of this very good therapy you should do. Why don't you give 2 doses? Or why don't you give 3 doses? And dude, why don't you give higher doses, like 50 milligrams? Do it, because 30 is not enough for these people. Why don't you try LSD? Why not some acid? Why not some MDMA? Why not compare the three of them? Why don't you give both at the same time? Yes, I'm not kidding. I actually heard suggestions like this. And yeah, again, joke aside, these could all be very interesting studies to do. But the problems, of course, is there are many reasons why it's complicated. First of all, money. Yes, of course, there's never enough money to do a complicated study. Also, never enough people to work on these studies. Also, as I told you, we want to retain patients in the study, so we want the study to be, let's say, as comfortable for them as possible without too many medical procedures. And of course, then there's all of these laws that are difficult when you want to investigate drugs. And yeah, I guess that's like what my hands will look like when the study is done. So where are we at? I have gotten a research grant by the Belgian Research Fund, so to support my time as a doctoral researcher in this project. The protocol is done, and I'm gathering all the documents to submit it, and I'm still awaiting financing options for the project itself. So really, best case, very optimistically, could start in the beginning of 2025. And thank you.
Hello, good evening. My name is Cisse and I work as a psychiatrist at the Gent University Hospital. And we've been conducting a small trial there since May. It's called the Psychos-D trial. It's for psilocybin in hospitalized patients with treatment-resistant depression. So this is a trial for patients with treatment-resistant depression. It's an open-label feasibility trial, so it's a small trial. Everybody knows that they're getting the psilocybin. There is no placebo or control group because we specifically wanted to assess if the safety and feasibility mainly of doing this within a hospital, within an established depression ward where there is already a lot going on. So the in- and exclusion criteria are very much the same as the ones you've been seeing all day, except maybe one specific inclusion criterion, and that is that the patients need to have a partner, a romantic cohabiting relationship of at least 1 year, because we specifically also want to assess the impact of the psilocybin-assisted therapy on the romantic relationship. As we've heard before that this might be interesting, and we know that there is a great impact of the depression on the relationship and the relationship on the depression. So yeah, this is the protocol more or less. People are hospitalized, as I said, for 8 weeks. This is a standard program at the depression unit of the Gent University Hospital. And during these 8 weeks, they get the standard treatment. They get all the therapies. These are mainly group therapies, verbal, non-verbal, and as a surplus in a kind of way to this 8 weeks of treatment, we do the study. In the first 2 weeks, there are 4 preparation sessions, and as you can see, all the points where there is this extra person, that's where the partner comes in. So there is one preparation session that is actually more like a relationship or a systemic therapy session, and then so for 4 preparation sessions before the first dosing sessions. There are 2 dosing sessions at week 3 and week 6. 25 milligrams of psilocybin, and then 1 weekly integration session after each dosing session, and the partner is present at 1 integration session after each dosing session. Also, the partner can room in, as we call it, so stay with the patient after the dosing session and overnight. Yes. We also do some EEG assessments before and after, also including the partner to assess some emotional aspects. Yes, and then afterwards there is a follow-up. So after these 8 weeks, there are weekly follow-ups until 3 months after the last psilocybin session, and then we do monthly follow-ups until 1 year after the last psilocybin session. So, as I said, it's primarily about safety and feasibility. safety, of course, all the adverse events, and because this is possibly a more severe patient group than the patient groups that have been researched in other clinical trials that have been mostly outpatients. And also so the feasibility, is it doable to implement this kind of treatment within an already existing depression ward? So we're also doing focus groups with the healthcare workers from the ward to see how they experience providing this treatment. And then the rest is exploratory, so we cannot say anything about effectivity as it's open label and small, and the EEG qualitative aspects. Voila, I should have had also a slide here with a thanks to all my team. I forgot about that, but I'm very grateful for everybody. And that's it, thanks.
All right, so we've discussed quite a lot about mental health here. So my talk is going to be a little bit more on the side, I have to say. So I'm going to present here some kind of preliminary results of the of psychedelics used for something completely different, that is post-comatose disorder of consciousness. So this is very much more on the neurological side. You might ask what these disorder of consciousness are. You might have seen these slides already because I actually had the lucky of presenting in the first symposium already 2 years ago. Disorder of consciousness are really neurological disorder that happen with patients that have a really big brain injury. They go into coma, they wake up, and what they have is they can show just reflexes, some behavior that is goal-oriented, but no functional communication or use of object. Laetitia shown before a very nice picture of a room. This is the kind of room we were talking about now. So this is really more on the hospital side, so with patient that's really issue with the communicating, really heavily medicated. So why I'm here, why I'm discussing about psychedelics? Well, the reason is that there's been a lot of discussion about what's the link, what's the demarcation line between being conscious or not, and a lot has gone around the concept of brain complexity. So the concept of brain complexity can be really thought as just a degree of integration differentiation in your brain activity. And this can be measured very easily with an EEG. What you can see is that all the state where you're conscious, like right now, where you're very well awake, or when you go to sleep, or but you're having a dream, have a kind of high brain complexity, while a state that are either spontaneously happening or pharmacologically induced, where you're not there, the universe does not exist, you're not present, have a low brain complexity. Now, what's interesting is that, as Dimitri showed at the very beginning, when you give up psychedelic to a healthy participant, what you actually see is that there is a boost, an increase in the brain complexity itself. And the idea will be, what will happen if you give these drugs to someone who have a pathological low brain complexity? Could you boost that in such a way that you could increase it to a more normotypical level? And so the idea was to use these substances to really try to ameliorate something that there is no real treatment for. So I had the luck actually to work with some people that are in this room using for first time a subanesthetic dose of ketamine, and here I'm just presenting the case for the very three first patients, the one that are going to be published. And what we observe is there was actually a nice increase in brain complexity, as the one that we would expect for a healthy participant, but nevertheless we cannot see really more behavior. So clinically speaking, we cannot see that dramatic change that we were hoping for. There were more time with eyes open, less spasticity, something very interesting on the side, but not the core change that we're expecting, unfortunately. I think if after we have time for questions, I'll be very happy if people are interested to go into more details. But besides this study that really happened here in Belgium, in Liège, actually was more Otigny, we had another very peculiar case where we could observe a patient who was able to show some signs of consciousness. Well, they had their linguistic ability preserved, who was given a liquid tincture of mushrooms. And what we observed is that we had a similar increase in brain complexity with no change in diagnosis. If anything, like every time we see this patient and we give them these substances, we see that the patients are less responsive. We don't know what's happening in their head. Maybe they're living a very nice experience, but from the outside world, it is very difficult to assess. In here, I was told that we had like 6 minutes, so I'll try to be as fast as possible. But if you were interested, there's been a very nice report that already came out about the case of this specific patient with psilocybin. So yeah, we observe. I like to joke that we are the first one that prove that psychedelics are not a panacea. So that's on the good side. I don't have a slide of thank, but thank to you, thanks for your patience, and thank you for your attention.
Hello. So I'm going to be as brief as possible because I think we are all very tired. I'm Aminata Bicego, neuropsychologist by training. I recently obtained postdoc grant, to carry out the study I'm going to talk to you about in the Netherlands. I hope to come back in Belgium to carry out other studies in Liège, where I come from. My background is in hypnosis, and so throughout my readings, my PhD, my postdoc, I realized that actually hypnosis can be a very relevant paradigm to understand psychedelics and psychedelics therapy, and starting with suggestibility. And so suggestibility is really regarded as a range of biopsychosocial processes that would facilitate the acceptance of suggestions. Suggestions can be considered as verbal statements, but I think that they can also be nonverbal languages, as how the therapist is positioned, how he moves, how his face is acting. And so suggestibility the research on suggestibility and suggestion has evolved in the same way as hypnosis research, as you see on the two graphs. We will see the same pattern of evolution, and I believe that the studies that we see in suggestion and suggestibility are actually have actually been done in the hypnosis domain. So I don't know if you are all familiar with hypnosis, but hypnosis is a state of consciousness involving focused attention and decreased peripheral awareness, which is characterized by an increased ability to respond to suggestion, so an increased suggestibility. It has 4 main components: absorption, which is the tendency to be fully involved in an experience; dissociation, which is the split of mental processes. So basically, during hypnosis, we might feel dissociation in the body. The hand feels heavy while the other feels light. Automaticity, which is a modified sense of agency. In hypnosis, people feel their behavior happening without properly giving the command. So the behavior is just happening, the thought is just happening. And then we have suggestibility, which is the compliance or the acceptance of hypnotic suggestion in this context. So hypnotic suggestibility, which is really the responsiveness to hypnotic suggestion. So here I'm talking about the hypnotic context, is assessed via standardized scales. We have it's really normally distributed. So we have quite low-high hypnotizable and quite low-high hypnotizable, and mostly the general population is mediumly responsive to hypnosis. Some authors think about hypnotic suggestibility as a trait, so something that doesn't really move. Others really believe that it's something that can change, and I believe this too. And so some studies indeed show that hypnotic susceptibility can be modified through neuromodulation, but also through the training of hypnosis and through psychedelics. So here is the link. And so here we have two studies. There are also older studies, but not a lot, strangely, because this is something that the clinicians in the field of psychedelics really talk about. They mentioned that psychedelics indeed increase suggestibility. And so we see that in both studies, the first one is on ketamine, the other is on LSD, the cohorts are quite small, and we showed that indeed after ketamine and after LSD, we have an increase in in the ketamine study, it was about hypnosis, so an increase in hypnotic suggestibility. And in the LSD study, it was really a scale on, let's say, suggestibility outside of a hypnotic context. And so with my colleague, Paolo, but also other colleagues, we thought about a study that would really assess this increase in suggestibility, and also if suggestibility is indeed increased after psychedelic intakes, then the importance of assessing the repercussion of a specific suggestion being said during the psychedelic intake. And so I had a fund for this particular study where we will compare placebo plus hypnosis, so hypnocebo condition, hypnodelic condition, which is a combination of hypnosis and psychedelic, but also a normal placebo condition. We will also use EEG to understand what is happening in the brain during psychedelic intake, during the assessment of suggestibility following psychedelic intake. And so we hope to better understand all these processes and how it works. We also thought about another study where we wanted to compare a low dose of psilocybin combined with hypnotic suggestions of mystical experiences to a high dose of psilocybin, which we know may lead to mystical experiences. And so, yeah, this is not a study that is yet funded. I hope that in 2 years, I will get some money to carry it out. But yes, so in conclusion, the renewed interest in psychedelic-assisted psychotherapy highlight the fact that research is needed. We know that there are external factors to the substances that could act as moderators and mediators in the clinical outcomes, such as suggestibility, but also the role of the therapist, as you mentioned before. And so those variables are known in the hypnosis domain. And so, yeah, it's really interesting to use the know-how of hypnosis research to then investigate those mechanisms in the psychedelic domain. Thank you very much. Thank you very much to the new team, to you, and to the PSBE.
We have time for a few questions for our researchers. Yes.
Okay, thanks for your information. I was wondering, because I want to do research as well later, and preferably in Belgium, but if not, I will go somewhere else, but whatever. I was wondering whether you encountered difficulties in getting grants with doing these trials because of its illegal status of the drugs, and what struggles you faced, and maybe it's easier in other countries. So what do you think?
So from my experience, it was not so hard to get a personal grant, but we are working with very little, operating money for the whole study. I don't think it's hard to get approval. You just, have to go through the regular, regulatory process for clinical trials. But I don't think it's harder. It's just a lot of work, and I think it helps when you are in a lab where there is already experience, and here there wasn't experience in the country, so we had to kind of all figure it out, I guess, all of us. But I don't think it's so difficult. It's a lot of work.
Yes, I agree with her. I mean, it's never easy to get funding, but I don't feel like there is any resistance here, especially because of psychedelics. rather the opposite.
Yeah, personally, I would say that, as Laetitia was saying, funding to the single people, it is not the biggest issue. At least for me, from my experience, was really more the finding the know-how. That is, imagine you start tomorrow. If you need a psychedelic therapist, we're gonna ask. You have some people here, but they might not be. Imagine that you want to do, for example, Liège. You need to find. I had to look for people that might either come to the place, or there is a scarcity of a figure that know how to do that. So I would say, yeah, grant wise, it's hard as always. And I think if anything with psychedelics, you're gonna have more chances to be funded, as Felix was suggesting. Yeah.
For me, it was difficult to get funding. We didn't get funding, so it was difficult. But we changed the design, the protocol, to make it as possible without funding. But then the process of the regulatory authorities, that was not so difficult, but a lot of work, as Laetitia said.
All right, I just want to react. Like, indeed, Felix and I took a very neuroscientific approach. Indeed, there was no mention of mystical experience in my application, but we do measure it. But yeah, you have to go through a system, probably working with that system. And I just wanted to say something. So Cisse said he had a hard time getting a grant, but I actually think his study is really great, because so there are some incentives, for instance, to do an RCT, randomized control trial, when you want to go through the FNRS or FWO. That was also your initial thing, right? And when you don't have money, it's much harder. In Flanders, they have a bit more money to fund projects without funding, but you have more flexibility. And I think therapeutically, the protocol that you have is very, very interesting and great, actually. Yeah.
I'd also like to add something. I agree with this neurobiological perspective, but also I think alcohol use is always a problem, but cocaine use disorder has been this massive problem these last few years. So I'm kind of lucky, maybe it's kind of the right time, and because the Belgian state is quite worried, the police is worried about all the cocaine users. So I think that also plays into it. It's not easy. I mean, I still don't have funds to do the actual study. I mean, although I have a half-time position paid by the FNRS, I don't have actual money to do the study yet. And there are not many funds where you can apply to, actually. There are less and less. Some hospitals, they stop actually funding research, which is a huge problem.
Another question there.
It's a question for Aminata. Speaking of mystical experiences, I was wondering if you could say a few words of your personal or scientific interest in the mystical experience, and then what would your hypothesis be for the mystical suggestions versus the psilocybin high dose group?
So reading the literature in psychedelics, really I understood the mystical experience. I know there are other factors that are acting or are at play during the psychedelic experience, but this is what we read the most. And I really saw it as a process of change, and I wanted to understand how this particular experience, call it mystical experience, call it ego dissolution, sense of unity, how this particular happening could then produce those lasting changes in the individual. So I got interested in that sense. Then for the study, so this was the first proposal I did for my postdoc, based on the hypothesis that psychedelics increase suggestibility. Then my idea was, then if I give a low dose, this will increase suggestibility. And so if I combine it to a hypnotic suggestion of mystical experience that I took from a study that assessed whether hypnosis could lead to mystical experiences, it's a script, I could maybe produce the same neurophenomenology as what is happening to a participant that takes a high dose of psilocybin and that experiences a mystical experience, because this is not always the case, but the idea was that. And yeah, to maybe also in that sense show complementarity and then maybe open trials to more people. Maybe.
There is one last microphone-less question from up there, but I trust Lionel to shout.
Yeah, no problem.
I knew it.
Comment. In fact, yeah, you were a bit, I would say, puzzled about the fact that you used mystical effect and it was not pleasing the FNRS. But I just wanted to say that the first project funded by the European Research Council about psychedelics, called Healing Encounters, was precisely about the way psychedelics are used in Amazonian medicine in order to translate it into Western medicine, and it was in anthropology. So just don't desperate, just try to find the best possible funder. Thanks.
Thank you.
If I may add,
Yes?
just try to understand really what are the values and what are the projects that are funded in the organization where you ask for the money. So there is always this thing that we say in research: write the project to get the money and then do your project. So, yeah.
Thank you. Please, a round of applause for our researchers. Who can go sit? And to close this day of symposium, we'll have a closing speech by Lennart Koch, one of the founders of PSBE.
All right. Thank you, everybody, for coming out. I think everybody is quite saturated. So if you'll do me a favor, take a deep breath in and out. One more time. Now, with that newfound energy, I would like to ask all of you to give a really, really big round of applause for the volunteers that organized this. Please now.
Let me just name them because there are many and they deserve to be named. All the people who organized the symposium, but also who made the brochure you all received. And yes, many other things. Anka, Audrey, Brigitte, Cédric, Catherine, Diane, Dieter, Eneko, Laetitia, Lima, Margot, Nadia, Nick, Ovidiu, Quentin, Tom, and all the PSBE working members who are all volunteers. A big round of applause.
Yeah, thank you, Olivier. So this is really a call to action also from us. We would like to hear more people talking about psychedelics. It's no longer as a taboo as it was a while ago. So if you have experiences, talk to people about them. If you're a psychiatrist or a psychologist and you're curious about psychedelics, also give them a try. Have the experience, do some of the work, why not? Yeah. If you're a politician, then please help us out. And for all the lawyers out there, please also contact us and help us out on the legal matters. Yeah, I think this needs to be a collaborative effort, and it needs to be multidisciplinary, and that's what PSBE stands for also. Yes, we shouldn't praise them as golden bullets that fix everything, but I also think we shouldn't put them down too much. Yeah, they also do fantastic work. They change lives, especially if it's done by the right people. Integrity is everything with regards to the therapists doing this work, and I think we heard a lot about that today, so I'm not gonna stretch this any longer for that. Any reporters in the room, feel free to reach out to us and also write some articles about this stuff. I think the more this becomes visible, the higher the likelihood politicians will also be inclined to actually talk about changing the laws in this direction and make it part of their political program. I think that's about it. I'm really, really happy you all came. So a big round of applause to all of you as well, because you all made this possible also.
And just on a practical note, this has been filmed, so the videos normally should appear in a few weeks, hopefully, on our website. Feel free to stay around because the bar is open until 8 p.m., I think, and you can just discuss and drink a bit more. Thanks for being here, and see you next year for another symposium, which will likely be on psychedelics. Thank you.